This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm TG LaFredo, and today I'm coming to you from KRMC's Wallapai Mountain campus. My guest is Dr. Michael Sheehy. He is board certified in emergency medicine and addiction medicine. Dr. Sheehy, welcome to the program.
Well, thank you for having me.
Thank you. I have been looking forward to this chat. You have recently begun a practice in addiction medicine, true?
That is correct.
But you've been practicing medicine for a long time.
Yes.
So I want to talk about your practice of addiction medicine, but I think a nice place to begin is how you got here.
Okay. Well, as we've talked about, I started in medicine way back in 1997 when I graduated from Michigan State College of Osteopathic Medicine. And I did a residency in emergency medicine. That was always my passion. I loved the TV show Emergency when I was a kid, and so that got me interested in emergency medicine. And I did that residency, and of course during that time I was exposed to a lot of patients coming in with substance use problems. Back then we called it addictions, and usually those were the patients you didn't want to have to see. You didn't want them in your ER, and you wanted to do your best to not give them anything and get them out of there as quick as possible because they were going to be a problem for you. And over the years of practicing medicine, I started to realize that was not the proper way to take care of people, that they have a illness just like anybody else that I would see in the emergency department, and I wouldn't treat a person having a heart attack that way, or a person having a stroke, or just a diabetic, or anyone else. I would treat them with compassion and kindness and the best care that I could provide for them. Probably, I want to say between 7 and 8 years ago, the state of Arizona Board of Osteopathic Medicine made it so that we had to do training every year on taking care of patients with substance use problems to maintain our license. And the Arizona chapter of the American College of Emergency Physicians, which I'm a board member of, started to do training in that. And it turned out there's a lot of ER docs who are practicing addiction medicine. And I just started getting this feeling like this is something that I'm very interested in doing and would want to do, and discovered that it's just a year-long fellowship of training, and there's 4 programs here in Arizona. So I was thinking, I could probably do that at some point in time and get into this. And, I always say that emergency medicine kind of has an expiration date on your practice because you can only work so many nights, weekends, holidays before you start to realize that it's a hard job, especially 12-hour shifts. And
your family reminds you it's a hard job
yes,
too, right?
Yes, and your lack of sleep when you work nights really starts to take a toll as you start to get further along in the field. And then COVID, of course, came along, and that really changed everything. It just got to the point where it was the hardest job that I ever took on, that it was just very difficult to provide the care that I wanted to do. And that really kind of pushed me forward to, what am I going to do with my life? I'm too young to just call it a day. And that was not what I thought I should do. And it came to kind of a head. One of my partners developed an illness that was going to prevent him from practicing emergency medicine anymore. And in his effort to find a way out, he discovered that he could sell our company that we had started. And if we sold this company, we were most likely going to be in a financial situation where a year off to go work in a fellowship would be economically feasible for me. And so we made the leap. We sold the company, and that allowed me to apply for fellowship and go do that for a year down at the University of Arizona at Tucson. I graduated last July, and it's been now since July that I've been working on all the things that require you to do to start a practice, which I really had no idea, because as an
been a
ER
while.
doc, you just kind of show up and it just happens. Whereas like when you make your own practice, you got to get insurance set up, you got to get your medical records set up, you got to get re-credentialed in a new specialty.
You have to do a radio interview.
You got to do a radio interview, which is great. You know? I don't think I've ever done one before.
Okay.
So.
You would never know. You didn't have to confess to that.
Yeah.
You described the shift in your perspective about addiction from when you were a student and you said, oh, we don't want to deal with these people. Let's get them out as soon as we can.
Yeah.
And then over the course of your career, you realized they needed more care. Does that also reflect a shift in medical thinking overall? Are there a lot of doctors who are having that same reflection?
I think so. When I started in medicine was when the government added pain as a fifth vital sign. And they did this for what was probably a very good idea, and that was patients shouldn't come to the hospital or their doctors and be in pain and suffering, because that makes everything about your care harder, and it takes a toll on the person and makes their healing much slower. The problem is that we went too far the other way. We just started handing it out to everybody. We based our patient satisfactions on how well we controlled their pain, which then led to abuse of it. And then at some point in time in the early 2000s, we said, oh, we should stop doing this. So we just said, stop giving out the meds. Well, all these people were already where they were addicted, to use the term. And so when they no longer get it, they went to the streets. And the cartels were more than happy to provide it. And it was more economically feasible for most people to switch from pharmaceuticals, which cost a lot per milligram, to heroin. And then we started to see that uptick in people dying. And we started realizing, and I think all doctors started realizing this, like they're having patients that were just everyday pain patients that they were seeing in their office. These were not people who were the stereotypical drug users. These were like, people with jobs, people with families, people who, some of them were doctors, and they ended up overdosing and dying, and started realizing like, we have to treat this in a different way. We can't just say, oh, you made a mistake. This is all your fault. The research shows that yes, the first time is oftentimes a choice, but after that, your brain is changed by these drugs in a way that you cannot just combat on your own, and it just won't go away on its own. It's going to be, a true illness that needs to be treated, and you don't just stop and walk away and say, I'm better now. It's a process.
In years of doing these interviews with people involved in all different areas of addiction medicine or law enforcement or courts or harm reduction, this is a point that almost everyone has made to me. You think you know what a drug addict looks like, or someone who's struggling with addiction. You may think you know what that person looks like. And they're around town and in the cities, there are those evident examples, but it goes so much deeper than that.
Yeah. Usually if you're seeing them on the street, those are the patients that are the sickest of the sick. And I hope that we can reach those folks, but I also hope that in practicing this, that we find them before they get to that point where they've lost everything. They're on the street, and they're at the point where like they might overdose and die. There are people who they just want to be out of pain, but eventually they just want to not get sick anymore from withdrawal and craving, and that's that balancing point before things just fall over the edge and everything goes where they're going to end up on the street, or they're going to end up with an overdose and die.
You described the shift in your thinking over the course of your career regarding addiction. Was that a long, gradual shift, or did you have some sort of aha moment or something that touched you, if I may ask? Was there something that you said, what do I want to say, like an immediate sort of moment?
Somewhat gradual, just because of the fact that, as an ER doc, you saw the the worst of the worst. And so, but you started realizing that it was just not just the stereotypical. It was people who were just everyday people who got to the point where they had a substance use problem. But probably between doing those classes with the college to get our yearly training, but also in 2016, I came to Christ, and it really, at that point, being born again, brought me to that point where I was like, one of the teachings of Christianity is that Christ didn't come for the well. He came from the sick, and he didn't sit down with the well. He sat down with the people who were demon possessed, the people who were, the tax collectors, just the worst of the worst, the people that everyone looked down on. And, that's where I should be as well. Help those people who actually need it.
The name of your practice in treating addiction medicine is the John 3:17 Clinic, and you've alluded to that. Can you talk a little bit about how you arrived at that name?
So I think most people, even those who aren't Christians, know John 3:16, which is that God so loved the world that he sent his one and only son. But the verse that comes after that, I think, is probably as important and probably as profound, which is that he didn't send his son to condemn the world, but he came to save it. And in addiction medicine, I'm not saying that I'm here to save the world. I'm not, but so many people, they're so condemned because of their substance use problems. There's so much stigma. And I want them to know when I come to see them that that's all off the table. Like, I'm going to help them in any way that I can to help get them to where they can get their lives back. And that's what that means, And so no condemning, there's no punishment, one of the things that a lot of my patients ask me is, how often do I get a drug screen? And it's like, well, the drug screen in many places are used for punishment. Like, you get caught with a drug in your system, they're going to stop your treatment. How I'm going to use that drug screen is if it's positive for something that we don't expect, we're not going to call it dirty. We're going to call it unexpected. And we're going to use that. Like, what's going on? What could we be doing better to help you so that you don't have to use these other substances? Because all these other substances are oftentimes because they're not fully treated, or there's something still going on that needs to be addressed to help them get past that.
You and I are both part of a group called M-STEP, and I've talked about this on the program, but it's Mojave Substance Treatment and Education Prevention Partnership. This is a multidisciplinary group that brings together a lot of community stakeholders, and as I mentioned earlier, medicine, law enforcement, education, all kinds of people. And we're looking at the drug problem nationwide, but specifically here in Mojave County, and we're putting our heads together to think about how we can address these problems, and not so much in the traditional ways, trying to find a new way forward and realizing that addiction has touched so many more lives than it did. We had to have some kind of change in perspective. We had to figure out a new way forward, or even if maybe we don't know exactly what that is. But what you're talking about is, what I'm talking about is there are a lot of people here who are pretty radical in their acceptance and in wanting to help these folks instead of ignoring them. And this is a conservative desert town. Have you had any pushback? Have you had any people saying like, oh, this is the wrong approach to coddle these people?
Yeah, it definitely comes up. It's not as bad as I thought it would be, but I do hear that. And, what I always say is I try to explain to people that what we're looking to do is not to coddle them and not to facilitate further use, but everything that we can do to reduce harms. So if we have to give out clean needles, that's going to prevent people from getting HIV, hepatitis, Plus, it's been shown that when you do these things, that's contact with treatment. And oftentimes, by showing people who are using that someone cares about them, opens them up to treatment, brings them to that point where they start to realize people do care and want to help them, and then they want to get help. Most people will tell you, if you ask them if they have a substance use problem, if they could stop, would they? Nearly all of them say yes. And the ones that don't, they're just not in the right place yet. And someday they will, and hopefully before, the old adage was when they hit rock bottom. But unfortunately with fentanyl, rock bottom is dead. Yeah, and I can't fix that. I know that from years of working in the ER.
Yeah. Where is the line between helping people and enabling them?
It probably varies from patient to patient what they're using. I would say that if your gut feeling when you're taking care of this patient is, they're purely using me to get a substance and they're not following the treatment plan, you're finding that they're visiting other doctors and also getting other drugs.
Yeah, doctor shopping.
Yeah, if you're consistently having drug screens that are coming up with other substances in there and they don't want to talk about why there's other substances in there, they don't want to address these other issues. But it really is. It's going to be patient to patient and substance, and it's not an easy answer to that question, unfortunately.
Yeah, that's why I asked.
Yeah.
What is, we think we know what, in a popular sense, we think we know what addiction is, but what is a medical definition of addiction?
That's also, it varies from what society you're talking to, and the society that I belong to that really manages addiction medicine is the American Society of Addiction Medicine. And probably how I would say that they define addiction is, it is a maladaptive use of a substance that affects you both socially, medically, and mentally, so that you are controlled by that substance or that activity in a way that you do not want but are unable to stop on your own.
If you're just joining us, this is Focus on Your Health. I'm T.G. LaFredo, and this week on the program, my guest is Dr. Michael Sheehy. He is board certified in emergency medicine and addiction medicine, and his addiction medicine clinic is the John 317 Clinic. It's a service of KRMC. And for more information, you can reach him at 928-352-1197. That's 352-1197. Dr. Sheehy, there are a lot of different ways people seek treatment, from counseling to 12-step programs. You come at it from a medical standpoint. What does that mean for your patients?
Correct. I believe that when you treat a substance use problem, it does need to be multi-pronged approach to treatment. So I'm just one part of a patient's recovery. And the part that I specialize in is using medications to help people get out of that substance use. And how most of what I do in my practice is, the biggest thing that makes patients with substance use problems fail is that they experience cravings, so a want to use. They experience withdrawal, which is usually in some medications life-threatening, like alcohol and benzodiazepines, or non-life-threatening, but feels so terrible that you don't want to go through it. And that's usually stuff like opioids and stimulants like methamphetamine. So what I do in my practice and what addiction medicine is helping with medications that will treat their withdrawal and then treat those cravings and help reset their brain, which has been essentially hijacked by the drugs, so that they are comfortable, they don't crave, they don't have withdrawal, and then they can then work with counseling and 12-step and whatever other things they need to do to address what may have led to their substance use. In addiction medicine, we say that oftentimes trauma leads to addiction. So many people who have substance use problems, they have a long history, either childhood, adolescent, or adult trauma. And that's where that counseling and 12-step help is ferreting out what it is that caused this use and how they can learn how to also develop more pro-social ways of coping with these traumas. And a large portion of people who suffer with substance use problems also suffer with untreated mental illnesses, depression, anxiety, sometimes schizophrenia. And so that's the other key to this, is making sure that those other issues outside of a medical standpoint, now granted that psychiatry is part of medicine, but they need to have those areas addressed as well so that they can fully come at this from all the different ways that you're going to get the treatment. So in my practice, I don't treat what we define as severe mental illness. So people with fairly significant schizophrenia, people with significant issues with bipolar, but I will address and treat anxiety, depression, panic disorders, a little bit of personality disorders, because those medicines all will help with the treatment of the substance use problem. But my goal mostly is helping people with that first stage, which is the withdrawal, and then getting them past that withdrawal and outside of that craving, making them comfortable. Because when you can get a patient to the point where they're not craving and they're comfortable, oftentimes that alone will facilitate them getting to a point where they're going to start to have their life back. And probably the best example of what I do is with people with opioid use disorder, we use buprenorphine. It's a medication that is an opioid as well, but it's a much safer opioid because it's very hard to overdose on it. It's very long acting, so it controls the craving for a very long time. It also helps if people have chronic pain, because it's a pain medication, and how we dose it will depend on whether they have chronic pain or just opioid use. But you can take a patient that's using fentanyl, get them on buprenorphine, and you will not recognize this patient in 2 weeks. And they will tell you, I feel so much better. I'm not spending my entire day trying to find drugs, trying to not be sick. Because after a certain point, there's no longer that euphoria that they got when they first started using it. Now it's just, I don't want to be sick. I don't want to be in withdrawal. I don't want to be craving. So, and they put that in front of everything else until they get that away. So they will put aside their family, their friends, their job, their hobbies. Everything goes out the window until they get rid of that craving and that withdrawal sickness.
People familiar with this conversation will recognize certain terms that you're using and certain terms you're not using. For example, you mentioned substance use disorder. Back in the day, we called that drug addiction. And there's been a shift
Correct.
In the lexicon. Can you talk a little bit about that?
So, addiction and calling someone an addict really has fairly negative connotations. I mean, when you hear the word addict, I mean, we all think of probably the same thing, or many people think of, the guy on the street that's laying in the gutter, that's shooting up, they're stealing, they're not a functional human. Whereas a substance use disorder really moves it more into a medical diagnosis and a treatable illness. I don't know if it's the perfect term amongst our society and other addiction doctors. We really still struggle with what we should call ourselves. I mean, we say addiction medicine.
Yeah, and that's what your license says as well, right?
Yeah, exactly. And, but we don't like the term. Yeah. patients oftentimes come to me and they tell me, I'm an addict. I let them call themselves whatever they want to call themselves, but I'm not going to use that term. We wouldn't use the same disparaging terms on pretty much any other illness that humans have. But because this one has so many negative connotations in society, we really have mistreated these folks for years and years and years, and it affects them. They don't want to come to the hospital. They don't want to get treatment. And it's a shame because sometimes by delaying their care, they get so much sicker, or they're so sick in the hospital, but no one wants to treat that part, and then they leave. And then they come back even sicker. So it's important to address the stigma. And, it's okay for people to have those feelings. It's just not okay to express them to the patient, and you just have to realize that we all have those biases in our background. We're humans. That's how we think, and that's how we work. But that doesn't mean that we should share that with the patient. We should just think like, I'm a doctor. I train to take care of patients. This is my patient. They have a disease just like anybody else that I see. Let me address that. And if I don't know how to do that, let me find the people who can help me do that. It's just like anything else. If you're an internist and somebody's having a heart attack, you call the cardiologist. Well, if you're the internist and you don't know how to take care of substance use problems, you call an addiction doctor and you have them help you.
You make me think of my background in education. It's another career I'm not practicing right now, but I think it was Piaget who talked about unconditional positive regard. And that seems like what you're talking about here. And if we're honest about it, you're also dealing with a population that can oftentimes be difficult to have that positive regard. That is part of your mission, though, right?
Yes.
I mean, it's a hard population to love. That's what I'm trying to say.
But what's funny is people always say, how do you deal with patients like that? I find that very few, when I go to see them, are ever in a place where they're like, hey, I'm going to treat this guy like crap. Mm-hmm. They're really happy to see me, and the ones that aren't happy to see me, it's because they're not there yet, and I always say to them, okay, you know what? My feelings aren't hurt. I got thick skin. I say, when you're ready, here's my card. You give me a call. You can scream and yell at me all you want. I'm still going to help you when it's time, when you need that help. And most patients, they are just so happy that someone is there to help them with something that is so difficult for them to deal with, that they're just grateful, and I cannot tell you in the time that I've been doing this, that if you come at this that you're open with the patient, that you're honest with the patient, that you are willing to help and accept them and not to stigmatize them, they're just happy and they don't mistreat you. And I just can't think of any patients that truly just like were rude or difficult. And if I see that's happening in the hospital, it's usually because they're not being treated well and they're usually not getting the care that they need. And it's usually a pretty easy fix. It's usually make them comfortable. And sometimes making them comfortable isn't providing them with the drug that they are using. It sometimes is another medication that just fixes whatever's making them feel terrible.
When we talk about, for example, fentanyl, tobacco doesn't seem like it's all that important in the conversation. Yet I have a note from you that you want to talk about tobacco. Why is that?
Well, it is probably the most deadliest drug that is legal universally in the world. I think there's one country in Scandinavia that is trying to become tobacco free, but technically they're not, because they're going to still allow nicotine products. But 60% of people who are long-term smokers, and that's probably anything over about 5 years, are going to develop some sort of tobacco-related illness that's going to lead to their death. That's significantly higher than any other drugs. Now, fentanyl overdoses seem like so much more dramatic because it's the short term. People die in the short term from using this. But I guarantee you, every person who smokes long term is going to develop some sort of illness related to that smoking. And 60% of those people are going to die related to that illness that they've developed from smoking, whether it's heart disease, COPD, or cancer. So those are some pretty phenomenally bad numbers. There's really good treatments for tobacco use disorder that will make people comfortable. And within substance use treatment, what we have found is that it's no more difficult for a patient to stop whatever their primary substance is, such as fentanyl, and tobacco at the same time. The other thing about it is that tobacco, because it is these fast highs and fast drop off and cravings, it actually facilitates continued use of whatever the primary substance is. So if we can get patients to not smoke and not to use tobacco products, oftentimes that will actually help them with whatever primary substance that they're trying to get. Not only that, but I mean, talk about savings of money. I mean, every time I pass a gas station, I'm always floored that a pack of cigarette costs more than $7. And I don't know how they do it. I guess I'm just cheap because I could never have a habit that I have to spend $7 a day on.
I feel the same way. Yeah, it's insult to injury, right?
Yeah.
As we've discussed, you treat addiction from a medical perspective. You are not involved so much in the counseling aspect of it. However, I know you've studied it. I know you've heard plenty about this. And what I'm wondering specifically is, if you are working with a patient, trying to help that patient through addiction and get better, what do you want that patient's family to know about that process?
Well, I want them to know that they will see ups and downs. Recovery is not a straight line. There's going to be good days. There's going to be bad days. There's going to be activities that they see that are going to infuriate them. That's not the patient doing that to infuriate them. That's the disease. That's that change in the brain. So, the best thing that they can do is be an advocate for the patient. So help them, but not enable them. Watch out for those changes in behavior so that they can help them see that there's something going on. And that's probably the biggest things, is just realize that this is a long-term treatment. This is not go to rehab for 30 days, got your family member back, they're going to be normal again. No, this is going to probably be the rest of their lives. And so you have to look at it that way. And the other thing is that you can't force them. You can gently, oftentimes, say what you're seeing, but if you try to make them do it, they usually will go the opposite way.
Dr. Sheehy, how do patients come to you? Is it by referral?
So I will see patients in the hospital. So if a patient is either in the emergency department or in the hospital, and they will call me and they will facilitate a consultation. So I'll come see them and make recommendations. I also, if they just want to have an appointment with me, they can just call the number that we've already said. And I don't have an office at this time. I do everything by telehealth. So pretty much the one thing that I need, and I think most people in the United States have these days, is a smartphone that has a camera and a microphone. Right. In a pinch, I will do it with just audio, but I prefer to be able to see the person that I'm seeing, because that helps me to do the exam that is in addiction medicine, because addiction medicine is really more of a talking specialty, but you can see the cues of withdrawal or use over a telehealth visit.
Yeah. And how does insurance figure into that equation?
So at this time, I'm working on pretty much to try to get all insurances. At this point, I'm going to see whoever calls me or is in need of care, and we'll figure out that part as we go along. I don't want anyone to feel like lack of insurance is going to be a reason for them not to be able to be seen. We'll figure that out.
Yeah. Well, we've covered a lot of ground in a fairly short amount of time, and we've touched on some of the social changes in drugs and in public perception of drugs and in medical perception of drugs. And so I guess I'm going to ask you to prognosticate a bit. What does the way forward look like to you?
Well, I think the way forward is going to be to continue to accept this as a medical diagnosis, an illness, and not a moral failing. The next step is changing the way we take care of people in the legal system. Like, so many people go to prison or to jail because of low-level drug crimes. That's never been shown to help people get better. Usually actually makes their life worse, because in jails and prisons, that's probably the easiest place to get drugs, which sounds backwards, but it's true. So, I'm not saying legalize drugs. I'm not a big fan of just everything being legal, but if you're not selling large quantities of drugs, prison is probably not the place for you. If you get caught with small amounts of drugs, it should be treatment. And that's why drug courts are really probably the place where we go, because we will save, in the end, we'll probably save money by keeping people out of prison, and we'll save lives by keeping people out of prison. And then we need to work with the governments that are allowing things like the chemicals that make fentanyl so easy to manufacture, get them to not allow it to be so easily done. Because unfortunately, most of the base chemicals to make fentanyl come from China, and China really just does not regulate that. And they know what's going on, and they just, for some reason, and I don't know the politics of China, but it just makes no sense to me, and it probably is a money thing.
I made the international sign
yes.
for money.
Yes. I think those are probably the areas. Just change how we think about people with it, and change the way we treat the folks when they are needing treatment. For people who are in the throes of substance use, I want them to know that there are ways out. There are treatments that are going to help them feel better, and they should seek the care and realize that this is not something that they have to do forever, that there's ways out. And then for society in general, stop stigmatizing people with substance use problems. Think of them like everyone else. They're human beings. They have an illness. Help them. And the first thing you can do by helping them is not to stigmatize them.
That is Dr. Michael Sheehy. His clinic is the John 317 Clinic. It's a service of KRMC. He specializes in addiction medicine. And if you'd like to speak with Dr. Sheehy, you can reach him at 928-352-1197. That's 352-1197. Dr. Sheehy, thank you so much for your time today.
Thank you for having me. It's quite enjoyable to get to talk about this.
And that is the program. Let's focus on your health. I'm TG LaFredo. Thank you for listening. Stay healthy, and we'll catch you next time.